Hello.
Hello. Yeah.
Sir, you can start whenever you want. I already opened the room.
Okay. I am audible to you, no? Very well.
Yes, sir. Yes, sir.
2 minutes I will start. Yeah.
Okay. Okay.
Yeah. Okay. Shall we start? So good evening to all of
Sir, just 1 minute. Just 1 minute.
yeah, no.
SKK, whose name is SKK. Request
Yeah.
to please stop your mic. SKK. Sir, you can start now.
Okay. So good evening to all of you. So this time I will initially show 2 short cases before going to the case proper, real case proper. So I'll start my share screening. Okay. This is a story of a 50-year-old lady who was presented with severe burning pain of both legs, apprehension, palpitation, and restlessness, and twitching movements of both legs for the last 2 weeks. This is the only story in this patient. Now, this is the only positive finding which I could get was this normal movement, twitching movements of this muscle. This is present in the calf, the thigh, and both the lower limbs.
It's called the myoclonus.
Neuromyotonia.
We'll just see, I'll come to finish the whole video. This is in the calf.
രണ്ടാമത്തെ കേസ് മൂന്നാമത്തെ കേസാണ് കാണുന്നത്. ഒരാൾ ഫൈബ്രോയിഡ് യൂട്രസ് എന്ന് പറഞ്ഞിട്ട് അത് പോയി ഒരു ലേഡി
It was present also on the thigh. And very clearly in the thigh.
എല്ലാ ചെറിയ കണ്ടമ്മ നിങ്ങൾ കണ്ടോ ഇത്?
It is also present on the opposite leg.
അതെടുത്തൊന്നും പറഞ്ഞില്ലല്ലോ നിങ്ങളിത്.
Is she saying this for the first time?
Pardon?
ഇല്ലായിരുന്നു.
അല്ല അവര് ആദ്യമായിട്ടാണോ കാണുന്നത്? Is she seeing this for the first time?
Okay, what do you think about these stretching movements on the legs?
Neuromyotonia.
Neuromyotonia?
Myopenia.
Myoclonus. Okay, myoclonus. Okay. Okay, let us see. What test would you like to do?
EMG.
EMG, middle ear.
Okay, EMG. Okay, let's see the EMG. This is EMG of the patient. These group discharges.
Doublets.
What doublets?
മൂന്നെണ്ണം ഒരുമിച്ച് വരും. മോട്ടയുണ്ട്.
Will come later on. This is a sometimes doublet, sometimes 3 or 4.
Spontaneous activity.
Spontaneous activity. The mercury poisoning.
This one.
Mercury poisoning മാത്രമേ വരുള്ളൂ.
What is discharge sensitive of?
സാധനം ഇങ്ങനെയല്ല
Neuromyotonia.
It's not neuromyotonia. Neuromyotonia is got a
സെയിം പാറ്റേൺ ആണ്.
thinking effect, very high frequency discharges, like that it comes.
മോർണിംഗ് വെച്ച്
Fast frequency discharges in a row. From the beginning, it is large and wanes off gradually. That is neuromyotonia. This group discharges occurring recurrently. What is this EMG suggestive of?
Myoclonus.
This is suggestive of myoclonus. Perfect. So this EMG shows myoclonus. So I'll show, for the completion's sake, I'll show one video from the Shapiro's textbook of EMG. This is that from that discharge. This one. Myoclonic discharges. This group discharges. See the sweep speed is only 10 milliseconds. It is widened to show the dual discharges. Maybe doublets, triplets, or multiplets occurring in a recurrent fashion. No, so the sweep speed is changing.
Classically.
This is discharge, just like our patient had. The speed in which we record was 50 milliseconds. This is 100 milliseconds. This is typical myoclonic discharges. So, what is the final diagnosis in this patient? 2 weeks duration, along with this burning pain in the limbs, restlessness, apprehension, palpitation.
Thyroid, sir.
Pardon?
Morvan syndrome. Thyroid.
It could be Morvan syndrome. Right?
Could be some toxicity.
Yeah.
It is a massive.
Right. Personally, this is very common with Siddha medicine. Do you know what Siddha medicine contains? Mostly contains mercury. This patient had very high levels of mercury in the blood. So this mercurial poisoning produces this kind of a typical apprehension, palpitation, burning pain. Sometimes the burning pain due to neuropathy can persist for months. And the muscle will show classical myoclonic discharges. So sometime back I showed that these patients can have Casper-2 antibody, which may be mistakenly diagnosed as Morvan syndrome. So this antibody can be triggered by these Siddha medicines. Okay, I'll go to the next short case.
Sir, thyroid can also cause, no, sir, hyperthyroidism, palpitations, sweatings, except for the neuropathy.
And these myoclonic discharges are not there in thyrotoxic. Other things can occur. These twitching, ventilating, worm-like movements of myoclonia is seen in these conditions. Morvan syndrome is another possibility, again the same thing. Okay. So another case, this 28-year-old female is present with ataxia and diplopia of 2 weeks. There are a lot of findings. I can share the video, play the video once again if you want, but you have a close watch.
Let's see here. Let's see its focus. The small movement should come in the right. ഇവിടെ നോക്കുമ്പോ പെട്ടെന്ന് തല ചരിക്കണ്ട അമ്മ. ഇവിടെ നോക്ക്, വലത്തോട്ട്,
The right side,
ഇടത്തോട്ട്,
into the left.
ഇടത്തോട്ട് നോക്കുമ്പോ നോക്കി എന്റെ പേരിലോട്ട് നോക്കിക്കൊണ്ടിരിക്കട്ടെ. വലത്തോട്ട് നോക്കുമ്പോ you can see the adduction failure also in the left side. ഇടത്തോട്ട് നോക്കുമ്പോ not only the slowing but also the adduction. ഇവിടെ നോക്കുമ്പോ ഇടത്തോട്ട് the plane of your head, so that
It has to look up.
താഴെ നോക്കിക്കോ. താഴെ നോക്കുമ്പോ
Looking down.
ഇടത്തോട്ട് നോക്ക്, അറ്റത്തോട്ട്
convergence. Okay, you want to see the video once again? I think I'll show the video once again. Okay.
Let's stay here now. Let's see its focus.
It's a primary position.
Movement should come in the right eye. Like this. ഇവിടെ നോക്കുമ്പോ
Into the right.
അല്ല ചിരിക്കണ്ട അമ്മ. ഇവിടെ നോക്ക് വലത്തോട്ട് ഇടത്തോട്ട് ഇടത്തോട്ട് നോക്കുമ്പോ നോക്കി എന്റെ പേരിലോട്ട് നോക്കിക്കൊണ്ട് വലത്തോട്ട് നോക്കുമ്പോ you can see the adduction failure also in the left side. ഇടത്തോട്ട് നോക്കുമ്പോ not only the slowing but also the adduction. ഇവിടെ നോക്കുമ്പോ ഇടത്തോട്ട് the plane
The patient has to look up.
ഉള്ളോട്ട് നോക്കുമ്പോ താഴെ നോക്കിക്കോ താഴെ നോക്കുമ്പോ ഈ ലെറ്റിലോട്ട് നോക്ക് അറ്റത്തോട്ട്
Okay. So what are the ocular abnormalities in this patient?
Square wave jerks and INO.
Very good. Square wave jerks are there. Anything else? And sometimes the square wave jerks are repeatedly occurring. Square wave comes and goes, but sometimes these repeated square wave jerks occur.
Cardiac oscillation, sir.
That's called macrosaccadic oscillation. Very well. So when square wave jerks occur with increasing amplitude and decreasing amplitude, when in continuous fashion, you call it macrosaccadic oscillation. Now, one more finding is there. I'll show the initial part of the video. The first part. I'll show the first part once again. Look now very carefully.
Lag is also there.
Yeah, apart from the eye movement. What is this movement?
in the right eye.
Pendular horizontal nystagmus, sir.
Yeah, correct. His inhalation has got a pendular nystagmus. In addition,
Small.
when it comes to square wave jerks, in between the square wave jerks, is the pendular nystagmus now? See the pendular nystagmus now? So in between, before it comes now, this is the pendular nystagmus. Okay, so what is the where is the site of patient? What is likely diagnosis? And one more finding is there on looking up.
നോക്കുമ്പോ
It's got an upbeat nystagmus coming on looking up, but not in the primary position. It's looking up, it's beating upward. So you can't call it a truly upbeat nystagmus.
ഈ ലെറ്റിലോട്ട് നോക്ക് അറ്റത്തോട്ട്
So what is that? This is a vertical gaze walk nystagmus. This point again, last class we classified, because to keep the eyes in the eccentric position, we need the neural integrator to stabilize the gaze in the eccentric position. The vertical gaze that the neural integrator is the initiation nucleus of the heart. But for that, the vestibular impulse has to transmit through the MLF to reach that INC. So in bilateral MLF, you often get a nystagmus looking upward. But it's only on looking upward you can not be like nystagmus. So it's called a vertical gaze walk nystagmus. So this patient has the following findings. Acquired pendular nystagmus, which is horizontal nystagmus fast beating. Square wave jerks and macrosaccadic oscillation. Bilateral MLF producing adduction lag. And vertical gaze walk nystagmus due to bilateral MLF. So what is the likely diagnosis in this patient? Without any history, nothing. If you find this constellation of findings, what is the diagnosis?
Multiple sclerosis.
Yeah, this is the whenever you get bilateral MLF lesion, first diagnosis is MS. And among the three causes of acquired pendulum nystagmus, the first one is again MS. Second is lesions, oculo, this involuntary triangular lesions of any kind. Then comes other rare conditions like people's disease, etc. So these are the two common conditions: is multiple sclerosis and lesions in the involuntary. Okay, so that is only a short case. Any questions in this case before I go to the proper case?
So this square wave jerks and macroscopic oscillation, can you just detail that, sir? Just to
Just one. Can you repeat the question once again?
square wave jerks and macroscopic oscillations, the difference and what is that?
Yeah. Saccadic square wave jerks, macrosaccadic oscillation, obscuranus, ocular flutter are all saccadic intrusions. Saccadic intrusions are one, abnormal saccades occurring when the patient is gazing at something. Okay, the resting position, or when you make a saccade toward make a saccade, attempt to make a saccade, spontaneous saccades occur. That is a saccadic intrusion. So normally saccades, when you ask the patient to one side or the other side, saccades should occur. Here, without asking the patient to do anything, the saccades should occur spontaneously. That's called saccadic intrusion. Something is intruding into our gaze. That is saccadic intrusion. So all these square wave jets, suddenly moving up and coming back, or macrosaccadic oscillations, obscuranus is multi-cavity, they're all saccadic intrusions. So they are generally thought to be due to the loss of inhibitory input from the omnipause neurons. The omnipause neurons usually keep the saccadic system under check because the PPRF is inherently unstable. So that has to be kept always inhibited by these omnipause neurons. So the omnipause neurons get switched off only when you make an attempt to make a saccade. The other situation when you blink the eye. When you close the eyes will move on. Apart from these two situations, always the omnipause neurons dominate and keep the saccades from not operating. For the saccades to operate, these omnipause neurons has to be inhibited. So what happens in saccadic intrusions is that this omnipause neurons gets dysfunctional. So the saccadic system will occur spontaneously. Saccadic abnormality, these intrusions will occur spontaneously without any.
The ocular flutter is only horizontal.
Yeah, correct. Ocular flutter is only in one direction, whereas multidirectional chaotic is the obscuranus.
Ocular flutter can it occur vertical also?
Yeah, it can also. Ocular flutter is usually horizontal.
Yes.
Please, but very, very rare.
Macrosaccadic oscillation and flutter, how will you differentiate, sir?
Because in ocular flutter, there is no intersaccadic interval. In fact, saccadic intrusion can broadly divide into two categories: those with intersaccadic interval and those without intersaccadic interval. Intersaccadic interval means when you make a saccade, before you make a saccade, back there is an interval. There is 200 milliseconds. That's always like that. You can't make it 2 seconds immediately, like in ocular flutter. Voluntarily, it's not possible. When you move the eye to one new point, even if you want to move immediately, there must be intersaccadic interval. That is about 200 milliseconds. So that the 200 this in square wave jets intersaccadic interval. You make a movement, only after gap it comes back. In the case of ocular flutter, there is no gap, no intersect, goes and comes like that. There is no gap like this. So that's the difference between ocular flutter and square wave jet, macrosaccadic oscillation. Because always there is a gap in between.
What about square wave jets and macrosaccadic oscillation? It's the same.
Repeated square wave jets is macrosaccadic oscillation. If macrosaccadic and square wave comes one side, it stops. Suppose the same thing, it goes to the other side, then goes this side, then goes this side. So in a continuous fashion, square wave jets occurring, it called macrosaccadic oscillation. So in the video, at one point, I can show the video once again. End point, it is occurring, repeated square wave jets are occurring. But the pendulum nystagmus is like a pendulum, like a slow wave moving in another direction. Here is a fast movement occurring repeatedly. This video has got a very Very interesting findings. So many findings. You want to see the video once again showing the macrosaccadic oscillation? I will show.
Yes, sir. Please, sir.
Yeah, I will show that. No problem. So I'll tell you when the saccadic.
It's the human.
This is fully pentile nystagmus. Now there's occasional square waves appearing. Pentile nystagmus.
Movement should come in the right way.
Now there's a square wave jerk. Like after some time it will come. Just wait. And this one, see that repeatedly occurring square wave jerks with a method intersaccadic interval. See that. And macrosaccadic
ഇവിടെ
oscillation.
പെട്ടെന്ന് തല ചരിക്കണ്ട
Other part. Then you can see on please you find the end.
Okay, sir. Thank you, sir.
Okay, shall we go to the next case?
Okay, thank you, sir.
Okay. This is a story of a man of 34 years. He gave his jerky movements of both lower limbs, resulting in falls for the last 17 years. Sorry, not 17, from the last 17 years, correct. And imbalance while walking for the last 1 year. And slurring of speech for the last 3 months. History in detail. The patient was apparently altered till the age of 17, except for one episode of febrile seizure at the age of 1. He studied up to 10th standard with the normal scholastic performance. From the age of 17 years, this patient was noticed to have jerky movements of both lower limbs, making him fall many times. Sometimes jerky movements will continue for a few minutes after the fall. The jerky movements had never affected the upper limbs, according to the parents. No loss of consciousness along with these jerky movements at any time. These jerky movements tend to occur when the patient attempts to move the lower limb, for example, whenever he tries to stand up from sitting position, or when he is extending the leg in the sitting position. For these jerky movements, patient had undergone treatment with various anti-epileptic drugs of various hospitals with no relief so far. At the age of 26 years, patient had one episode of GTC seizure which did not recur subsequently. He was put on treatment and subsequently there's no further GTC seizure. For the last 1 year, patient was noticed to have imbalance while walking, and for the last 3 months, mild dysarthria. This is a story. So you want to say the story once again. From the age of 17 years, he used to have recurrent jerky movements making him fall. Jerky movements occur in the lower limb, mainly when attempting to move the lower limbs. That's actually the story. Second thing was that he had this occurs when he is attempting to stand up or trying to walk, he developed these jerky movements. So it's mainly an intentional component is there. There's on many anticonvulsants with no relief for the myoclonus. Then for the last 1 year, he had imbalance and last 3 months he had mild dysarthria. So past history is born of non-consanguineous parents, no development delay, and other siblings are normal. And this treatment history is currently on Encorate Chrono 300 and 500, 300 morning, 500 evening, Chronotil 0.5 milligram 102, Lamictal 50 milligram BD, and Levetiracetam 500 milligram BD. There's no improvement in the frequency of myoclonus in these medications. Examination. This examination of the patient.
തിരുവനന്തപുരം എന്ന് പറഞ്ഞു
Mild slurring of speech.
തിരുവനന്തപുരം ഓക്കെ ഞാൻ തിരുവനന്തപുരത്താണ് താമസിക്കുന്നേ
Slurring of speech.
ലാ 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 എന്ന് പറഞ്ഞു ഓക്കെ എടുത്തോട്ട് നോക്ക്
It's good. Slowing of circuits in all directions.
അത് മാറി പ്രസാരമില്ല
Mainly horizontal.
ഇടത്തോട്ട് പെട്ടെന്ന് നോക്കണം ഇടത്തോട്ട് 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 ഇനി മുകളിലോട്ട് താഴെ മുകളിൽ താഴെ ഞാൻ പറയുന്ന പോലെ ഇങ്ങനെ നോക്കണം എൻ്റെ വിരൽ കണ്ടോ വിരലിൽ തന്നെ നോക്കണേ പെട്ടെന്ന് ഇങ്ങോട്ട് നോക്ക് ഇവിടെ നോക്ക്.
Again, it's slow. Even with visual cues, also it is remaining slow.
ശരി.
Morphospontaneous
ഒന്ന്
movements.
മുറുക്കി അടിച്ച മോനെ, മുറുക്കി അടക്കി.
The rest of the muscles separated by the canines were normal. No facial weakness.
ഈന്ന് കാണിച്ച് ഈ ആന്ന് പറ. അന്ന് പറ. ആ നാക്ക് നീട്ടും മോനെ. നാക്ക് അങ്ങോട്ടും ഇങ്ങോട്ടും തള്ളിക്ക്. അല്ലല്ല നാക്ക് അതിന് വലത്തോട്ട് ഇടത്തോട്ട് മതി. ഇനി കണ്ണാൻ കാണിച്ചു.
Then he has no pseudocytosis movements in the head.
ശരി, മോൻ പറഞ്ഞതുപോലെ ചെയ്യേ. എല്ലാം കൊടുക്കാതെ.
Tone appeared normal in both upper limbs, and power was also normal.
കൊടുക്കില്ലേ മോനെ? വിടരുത്, വിടരുത്.
Some suspicious hip weakness is on the right side, but all of the muscles were quite good. So maybe hip weakness may not be just at good power.
ഇനിയിപ്പോ ഇങ്ങനെ പിടിക്ക്. നൂർത്തേ മോനെ, നൂർത്തേ. ഇത് നൂർത്തേ. അത് വിട്ടോ.
There may be functional imbalance, and fingernails incoordination is there.
അത് വെള്ളം തൊട്. ഇനിയും തൊട്ടെ. ഇവിടെ തൊട്ടെ. ഇനിയും ചെയ്ത്. ഇവിടെ ചെയ്ത്. ഈ കയ്യിലുണ്ട് ഇത് ഇനി. കറക്റ്റായിട്ട് മുക്കി തൊട്. ഇവിടെ തൊട്. ഒന്ന് തൊട്ടെ. മതി. നീ ഇങ്ങനെ തൊട്ടുകൊണ്ടിരുന്നേ മോനെ. ഒരു
Lower limb power was normal.
വിട്ടോ, വിട്ടോ. പാദം മുകളിലോട്ട് എടുക്ക്. മുകളിലോട്ട് എടുക്ക്.
In fact, this video was taken by the bystander. That is not a good quality video. It's got mild incoordination in the lower limb. Upper fluids were normal. You can't see on the left side, but it was normal. I need it repeat in the next day. Normally situated.
മാറ്റിക്ക്.
Lower limb knee jerks were brisk. And just visible, almost absent on the right side. Just visible on the left side. One was subgoing. Sensations were all normal.
ഷോക്ക് അടിക്കുന്ന പോലെ. ഇപ്പോൾ ഉണ്ടല്ലോ. ഉണ്ട്. ഇപ്പോൾ ഉണ്ടോ? ഉണ്ടെങ്കിൽ ഉണ്ടല്ലോ. ഉണ്ടല്ലോ.
Able to feel the vibration.
ഉണ്ട്. നീ ഇപ്പം എങ്ങനെയാ?
Joints in the upper limbs normal.
അപ്പം അറിഞ്ഞൂടാ.
He made mistakes, but the second day examined it was he could tell it correctly. Probably was really inattentive on the first day.
ഇപ്പോഴേ ഇപ്പോഴേ
Well, this is important. He one time get up, he developed myoclonus and fell down.
എനിക്കത് അറിയാൻ വേണ്ടി തന്നെ.
Look at these myoclonus. I just got to see the knees sagging like that, jerking.
അടുത്ത് നിൽക്കും. നീ കയറി.
I made him to climb up again, go to the court. He falls down like that.
മോനോട് ഇരുന്നോ. സാരമില്ല മോനെ, സാരമില്ല. ഇനി മോനൊന്ന് എഴുന്നേറ്റ്. അച്ഛൻ പിടിക്കും. ഒന്ന് എഴുന്നേറ്റ്. എഴുന്നേറ്റ് വാ.
This myoclonus. This make him fall many times per day. Every day.
ഇപ്പം നിൽക്കുമ്പോ ഇറങ്ങി മോനെ. ഇറങ്ങി ഇറങ്ങി. അതിനെ കസലോട്ട് ഇരുന്നോ. ഇനി കസലിരുന്നു.
He jumps on the chair. Again, jerky movements. Continuously walking, not much a problem. Trying to move it, and immediately
മോനൊരു കാര്യം ചെയ്യാം. കസലോട്ട് ഇരുന്ന് നടന്നു.
clear it again. Okay, he's getting trying to stand by.
പാപ്പ തിരിച്ചു വന്നേ. തിരിച്ചു വന്നേ മോനെ.
So, an exam hybrid function is normal. One day normal. Slow saccades for both horizontal and vertical line movements, mainly horizontal saccades. Pursuit normal. First the canines when speech, mild, slurring, dysarthria. motor system, bone power normal in the upper limbs, except for mild hand grip weakness on the right side, which is slightly dubious, not very sure about. It are all normal in the upper limb, knee ejects bliss bilaterally, and ejects 1 plus bilaterally. Plantar upgoing bilateral. Senses small normal experiments APS over both toes, which was not there on the second day when I examined him 2 days later. So this video I took when we came to my house for consultation. I asked him to come for an admission 2 days later. And that time examined again when the APS was normal. Rhombus is mildly post-cerebellar signs is incoordination both upper and lower limbs. Tandem defective, aid by increased ataxia. And severe myoclonus lower limbs and attempt to get up, walk or sit. So what is your likely diagnostic possibility?
PMA syndrome, progressive myoclonic ataxia, probably due to mitochondrial.
Is it progressive myoclonus ataxia or progressive myoclonus?
Ataxia, PMA.
No, in PME, it's called progressive epilepsy syndrome. PME, because it's myoclonus. In myoclonus, he is also got seizures also.
Yes.
Generalized tonic-clonic seizures is controlled with medication. Okay, it can be progressive myoclonic epilepsy syndrome. Attacks is a possibility, but there you don't get generalized tonic-clonic seizures.
Yes, sir.
So what?
Sir, DRPLA, is it a possibility?
Yeah, DRPLA is one of the causes. Under progressive myoclonic epilepsy, many symptoms will come. And one is the DRPLA.
DRPLA dementia will be there, sir, no?
Pardon?
DRPLA, cognitive dysfunction will be there.
Yeah, there are many points against. First of all, DRPLA is very, very rare in India. When it was reported DRPLA. Secondly, it has got many other features. What is cerebellar signs, myoclonus, seizures, mental subnormality, hyperemeral signs, many things are there in so movement disorders. So DRPLA is a condition with many neurological findings. And myoclonus is one among them.
Sir, is this a propriospinal myoclonus stimulus or movement induced myoclonus?
This is actually, this is called proprioceptive myoclonus is still a dubious entity. Okay, so some people don't even believe in that. But here, actually, what you observe is got a myoclonus effect in the lower limb on attempting to move. So it's an industrial myoclonus. That's one that classically you get in all PMEs. You try to move, get severe goes into myoclonus. So other PME, epilepsy, commonly seen in India, neuron zero lipofuscinosis, there is psychosis, second is laparoscopy. In multiple myoclonus without any cerebral minimal cognitive impairment is not seen here. We diagnose it because we don't have any other diagnosis. Then the other condition is cyanosis. That is also not uncommon. I've seen 2 cases with thyroid spot on this thing. That is the other condition. Mitochondrial myopathy with ragged fiber, myoclonic epilepsy with ragged fiber. So what does she need now in this patient?
MRI.
Yes, a black dead nerve cell this case.
Before that, you the common things first, no? So we'll do MRI first. MRI into if you look very carefully, I'll show the other pictures. It's mostly normal, except for mild hypertrophy of the cortex, cerebral cortex. In picture, you see some hyperintensity.
Cerebellum also atrophic, sir.
They see that area, that middle temporal lobe, there's a hyperintensity lesion with some mass effect. If you compare with the flare, you can find out the difference. When you compare it with that, see that is the lesion on the right side, corresponding lesion on the left side. Left and higher sequence. Here, definitely hyperintensity lesion right middle. And this is the sequence. It's nothing much except the same lesion seen there. And cortical atrophy, mild cerebral. This is SWI. Sagittal cut. More cortical than cerebellar. Okay, this is only abnormality there. What else you want? What EEG, no?
Contrast was done, sir. Contrast. Contrast study was done, sir,
Contrast was not done.
for that lesion.
Yeah, but at least the enhancing one, no, agreed. That can't explain, no, this syndrome in this.
Sure, sure, sir.
EEG, sir. EEG in this case.
This is the EEG. But he was on Medicaid. This EEG was normal. I couldn't find any classical ischemia abnormality here. So, normal. Okay. So it did not elicit any photoparoxysmal response. So what will you do now? In terms of
CSF study, sir.
CSF study for lactate, I don't know. We is between the marks of the brain to find out lactate level. You can do that. It's long duration. No? You can totally reaches about 17 years.
CPK.
So clinically, it will be like Niemann-Pick tree, sir.
Yeah, that of course we can investigate for those things. And an easy way to make a diagnosis later, which will come later. So, in fact, this patient was examined after 2 days. I told you I saw him initially at my residence. 2 days later, I asked him to come for admission. So, I examined this patient on 2 days later. I think I'll skip this finding. Almost all same as before. Except that the reflexes were all normally elicited. That's what I will show in a second. They were normal. And Nijek appeared counterplus very suitable. Nijeks were at risk. And Nijeks were initially thought absent but was insipid. Is insipid. So initially I thought it was absent but was insipid. Is there. Under was subgoing, that was still present. And this sensation was, I checked again, they were normal. Is it capital? Look at his gait now. He could climb normally without any myoclonus, climb down without any myoclonus. Totally subsided.
Ammonia, sir.
And wait, just wait. Further. So I made him sit up and get up again to induce myoclonus. It's hectic otherwise. There is no myoclonus. It's totally subsided. I was also surprised that he improved so much within 2 days' time. Which I did not expect in this case. And he's so happy that he did not fall. So what did they do in this patient?
Sir,
Valproate
stop.
stop.
Valproate.
Pardon?
Ammonia, hyperammonemia.
Valproate was stopped.
Valproate, in fact, I increased valproate.
Lamotrigine, sir.
Pardon?
Lamotrigine.
Correct. That's actually the reason why. So I stopped lamotrigine totally and put him on sonizumab and gradually tapered off levetiracetam. Now the reason I will tell you later on. And why did I do that? Because the clinical possibility we all considered was progressive myoclonic epilepsy. There are certain anti-epileptic drugs which can worsen myoclonus. And one of them is sodium channel blockers. And lamotrigine is a sodium channel. So I just stopped that thing, and 2 days later, the myoclonus subsided. But one thing I did, I increased the dose of sodium valproate, but that I don't think might have been caused the subsidence of myoclonus. And I added sonizumab, but even before the sonizumab could take its effect, myoclonus subsided. Probably the drug withdrawal has produced this improvement. So as you know, sodium channel will aggravate myoclonus seizures. Before that, so that I searched the literature, find out certain other. This we must know because we are practicing physicians. We must know which are the anticonvulsants which can worsen seizures. Because you know that in sodium valproate is contraindicated mitochondrial diseases. Mitochondrial myopathy with seizures, with sodium valproate it will worsen everything. So something similar to that. Some contraindications or anticonvulsants which can worsen seizures. Carbamazepine has increased tendency to worsen absences, as you all know. Tonic and tonic seizures, as well as positive negative myoclonus in patient generalized form of epilepsy, if you give that thing. It can worsen primary generalized tonic seizure, JME you all know. Rolandic epilepsy sometimes you can get control with carbamazepine. Sometimes it can worsen rolandic epilepsy. And can produce cognitive impairment in benign rolandic epilepsy, so-called malignant childhood epilepsy. Specs. Emergent syndrome. And among children without previous seizures, if EEG abnormalities present only 10% seizures if we give carbamazepine. And carbamazepine can worsen continuous spike wave abnormality of the sleep. Lamotrigine has been reported to worsen several forms of epilepsy, and high doses can even produce a pro-convulsant effect. And in this myoclonic status epilepticus has reported Inches syndrome. Lamotrigine can precipitate absence in children with rolandic epilepsy. Levetiracetam, there's not much of a problem. Rapid dose increase or high doses of levetiracetam can lead to increase in the seizures in up to 20% of the patients, especially in children. In children, if you increase levetiracetam, should be given in a gradually increasing dose, not give a very large loading dose. Increase in the tonic and partial seizures, as well as development of long apneic episodes, as well as convulsive and convulsive status has been described with rapid increase in the dose of levetiracetam. With this lower dose escalation and lower maintenance dose, it is rare to see levetiracetam. Benzodiazepine, the drug of choice for status epilepticus, is contraindicated in Neurology syndrome because it can precipitate chronic status epilepticus. Anticonvulsants with the least tendency to worsen seizures are sodium valproate, topiramate, and sonizumab. This is only from the literature I gathered this information. So I thought I will share with you because it may be useful for practicing doctors like this. Now, what other tests will you do now? You had strong suspicion of progressive myoclonic epilepsy. Rather than checking lactate and all, what else can you do? Genetic test, no? Very good. So I did EVEP. Sometimes EVEP can be abnormal in PMS. That was normal. So SSCP was done. It was normal. There was no giant SSCP seen in this patient. The two conditions where you can giant SSCP in general, but especially in Lephora body and in CL. So I did ophthalmology consult and look for any specifically. I did not see in the cherry-red spot or retinal degeneration for NCL. then it was not there in this patient. No obligatory, no chorioidal lacunae, no cherylioids. Then what else you do? You do the genetic test. So this is the genetic test. Two abnormalities of uncertain significance came, that PLA2G6, that is NBIA, is unlikely to present in this fashion. Second, ASH deficiency, AH1 gene abnormality. Here the clinical percentage is spinal muscular atrophy with progressive myoclonic epilepsy. So whether it is really related to our patient or not, we do not know. So I searched whether this gene abnormality can cause any abnormality, condition like that. And before that came for 6 months, so 6 weeks. No further seizures of myoclonus. His postcoital palpitations, activated stop. This a few words about PME. I think I will skip all these things. I will go to only one thing. In India, this is a large study conducted in NIMS. They found that two common ones are NCL and laparabody disease. These are the common ones which you see in India. And then mitochondrial cytopathy. And probable unbridged inbox, which was not proved because only thing is we put any other cause, they thought this is the cause. I think I'll skip all these things. NCL, you can find giant SCCP. And for a body, you can also see giant SCCP. I will skip this SCCP. Now, looking back to gene abnormality, see, there is one case report in which this is the heading. Identification of a novel mutation of PLA2G6 gene abnormalities in the patient in a Chinese pedigree with familial cortical myoclonic tremor with epilepsy. There is a different presentation, but still this is one case report where this gene abnormality has been linked with myoclonus. So I think we'll skip all these things. There is another one going to the next gene abnormality. SMA without progressive myoclonic epilepsy is also caused by ASH. So this also I will skip. So this is the story of the patient. Probably PME, which type we do not know.
What was the medial temporal abnormality on the right side, sir?
No idea, no idea. Whether it's a hematoma or something like that, we don't know.
Would it be due to some mitochondrial thing like melas or something?
I showed the mitochondrial gene abnormality was done, which is I'll show that. I think I did not show that. This is a mitochondrial genome. No pathogenic or likely pathogenic variants causative mitochondrial genome.
Yes, sir.
The idea of bringing this case is only to highlight that there's the anticonvulsant choice of anticonvulsant should be very judicious in cases of myoclonic epilepsy. That's a thing which I would about this case. Now, I have seen many people.
Levetiracetam also can produce like a had a patient like he was on treatment from neurosurgery for a gliosis. He was having recurrent seizures, uncontrolled on multiple medicines, and when the EEG was taken, it was like slowing. When I reduced the levetiracetam patient for the seizures, I don't know. Rarely it can also occur.
Yeah, please, can you definitely.
Sir, the Ramsay-Hunt syndrome and the NCL are the same or different?
No, they are different. Ramsay-Hunt syndrome is one variety of a progressive myoclonic ataxia. Okay, that comes. This initially Ramsay-Hunt syndrome was called as particular entity, but they are all grouped under progressive myoclonic ataxia. It's hereditary ataxias with ataxia predominantly and myoclonus, but not generalized organization. What see, I have seen not one, not many cases, probably more than 10 cases I have seen. This thing also, they got intention myoclonus for a long period of time. Some of them with generalized tonic-clonic seizures, but no cognitive abnormality, no cerebral involvement, nothing. And over years, this has been continuing. Some of them got good response with sodium valproate and benzodiazepines. They are typically fitting progressive myoclonic epilepsy, but not progression as such. Some kind of a benign variety of intentional myoclonus. I don't know whether you people have seen that.
Yes, sir. I also have seen similar case, like boy actually looking like this only. He also had similar symptom. Some anti-epileptic adjustment was done. I was actually planning to refer him to Chitra, but to my surprise, actually, next visit he had no further seizures, and still on follow-up for 3 years, no further seizures at all.
And this
Till then, it was progressive actually.
It is a benign variety. And somewhere I read a report like that, patient like benign variety of BME like that. We don't do BME because it's not progressive. Intentional myoclonus and generalized tonic-clonic seizures. Profound intent, just like this. As Professor was telling. Okay, shall I go to the next case?
Yes, sir.
Questions? We can go. Before that, I will show another case of PMA which I have seen when I was in Amrita. Look at this patient's disability. He had so much myoclonus and the affect the facial muscles also, so he cannot even speak.
ആദ്യം നടക്കാൻ ഈ ഞെട്ടിൽ വന്ന് ആദ്യം കഴിക്കാണോ കാലിനാണ് ആദ്യം തുടങ്ങി? കൈക്ക് പിന്നെ കാലിനായി, ദേഹം മൊത്തമായി. ശരി, എത്രാമത്തെ വയസ്സ് തുടങ്ങിയത്?
Just like our patient has to get up from the chair.
നേക്കട്ടെ എഴുന്നേൽക്കാൻ നോക്കിയേ.
See the jerky movement, just like our patient.
നടക്കാൻ നോക്കിക്ക്, ശ്രമിച്ച് 2 ചുവട് വെച്ച് 1 ചുവട്. ശരി, മതി. ഇരുന്നു ബാക്കിരുന്നു. പറഞ്ഞേ.
So this is something just like our patient. This patient had also cerebral ataxia also. And this patient genetic test, I don't know. This is long genetic test was not that freely available.
Here, what is that facial movement, sir? Is it myoclonus or?
Yeah, it's all it's affecting the face, parietal tongue, that he cannot. The speech gets interrupted because of the jerky movement. If he attempt to speak, this myoclonus jerk will come. It's affecting the whole part. He said he himself is telling the whole limb, then upper limb, the whole body is affected. That is what he said. Okay. Shall I go to the next case?
Yes, sir.
Okay. This is a 26-year-old male. He noticed inability to move his right hand and elbow following a road traffic accident, producing fracture of the humerus. 2 months back, for which surgery was done. This happened 2 months back, for which surgery was done immediately. At that time, he was not able to elevate the right arm, which he could elevate now after the surgery. And he was put on a plaster, and after removing the plaster, he noticed difficulty in using in ICC. Whether it was present at the time of RT, we do not know, because he must have bothered only about the fracture. But this is the story. And let us see the examination of the patient. The findings is for the localization.
പിടിച്ച് നിർത്തിക്കാണ്.
Relatively good power. He could hold it against stab.
ഇതിനകത്തോട്ട് ഇങ്ങനെ എടുക്കാൻ പറ്റും.
Action of the elbow was weak.
പറ്റണില്ല.
He cannot keep his hand supinated. It goes into pronation.
Also is not possible.
Even mid pronation goes into pronation.
Remains pronated. ഇങ്ങനെ പിടിച്ച് നിർത്തിക്ക്.
He cannot keep it like that. He goes like
goes
that.
inside. ഇനി മോനെ കൈ ഇങ്ങോട്ട് തള്ളാൻ നോക്കിക്ക് എൻ്റെ കയ്യിലോട്ട്.
Biceps is also weak.
ഇത് പൊക്കി നിർത്തിക്ക് എങ്ങനെ?
It's got to pain here, so I cannot assess the wrist extension.
വിരല് പൊക്കിക്ക്.
Finger flexion is so much weak.
പറ്റണില്ല. Okay.
Now you see the introtiate.
Answering your question. ഇനി പിടിച്ചോ.
See, amplifying the extensors. I could listen the interphalangeal joint. See, that shows this introtiate and umbilicalism both good.
This is a good power.
His FDA is also normal. So also ADM is also normal. Good power.
That is also good power. Very മടക്കി പിടിച്ച്. മടക്കിക്ക്. അകത്തോട്ട് മടക്കിക്ക്.
Is normal.
അകത്തോട്ട് മടക്കിക്ക്.
His longness is normal.
മടക്കി പിടിച്ചോ. മടക്കി പിടിക്ക്. It's also good. പിടിച്ചോ. വേദന മറിക്കുമ്പോൾ പറയണം. ഇതറിയാമല്ലോ.
He is able to feel sensation there.
അറിയാം.
Over the thumb it is decreased.
പറയാം. ഇപ്പോഴേ
He is not able to feel there.
ഇവിടെ
Not able to feel there.
ഇല്ല. അറിയുമ്പോൾ പറയണേ. അറിഞ്ഞ ഒട്ടം പറയണം.
Not able to feel. When I removed the shed, then only I found that he's got multiple scars.
ഇതറിയുന്നില്ലേ?
He's not able to feel.
ഇതറിയാം. ഇത്
The other surface is able to feel. Arm also is able to feel.
ഇത്
Yes.
ഇതൊക്കെ അറിയാം. ഇതൊക്കെ അറിയാം. ഇവിടെ ഇല്ല.
Lifted his shed, I found he's got a multiple scar there.
ഇതൊക്കെ അറിയുന്നില്ല. അറിയുമ്പോൾ പറയാം.
Here he is able to feel. The mid arm upward.
ഇവിടെ അറിയാം.
Biceps is absent. It is normal on the left side. Supinatory is normal left side. Action on the right side. Biceps also absent on the right side. So this is the findings. If you want to see the findings once again, I can show. Otherwise, we can go for the localization. You want to see the findings once again, anyone? Okay. Okay. So on examination, weakness of right biceps, supinator, brachioradialis, extension of wrist, fingers, distant fingers, mild weakness of right biceps. Normal muscles are deltoid, rotator teres, plexus of the fingers, and flexus of the wrist, and introstate of the inner muscles. DT are all action on the right side. Sensory dulling over the right lateral forearm, extending down to the dorsum of the right arm. So very well localization.
Sir, please go to the normal muscles, please.
Yeah, sure. I'll show the slide.
Radial nerve and vasculocutaneous nerve.
Okay, right. All agree with that diagnosis? Okay, let's.
Says 6, 7 roots.
Okay, C6 is the company, right?
Roots. C5 being spared because the deltoid is okay.
Okay, correct.
Not just the radial nerve because I mean the dorsal cutaneous nerve of arm.
No, that is where radial may be affected distal, no? The lesion may be distal to that supply of the dorsal cutaneous nerve of the arm.
Yes, sir. Yes. Sir.
C6 on root, sir.
Okay, C6, that she was also telling C6, C7 root radiculopathy. The upper and middle trunk involvement.
Yeah, that's possible. But there are deltoid is paired.
Yeah, but deltoid is paired. So let us see the possibilities. Come back one by one. As somebody suggested, C6, C7 radiculopathy, you got to keep in mind this can explain everything. But what is against?
Mostly cutaneous nerve, the arm and forearm is the localization, the sensory.
Well, that part will be difficult now because with multiple cutaneous injury, whether that is due to that or not, not. And C6 radiculopathy, the sensory loss may be only confined to a small area of the tablet.
Wrist flexion. Wrist flexion is C6.
Wrist flexion is not affected.
Wrist
flexion is not
flexion is C6.
No, wrist flexion is C8. Normally C8, except flexor radialis, which is C7. Normal supply is C8.
Pronation is PET.
Yeah, that's the answer. So normal for the pronated teres. See, the pronated teres and supinated have the same supply, same root supply. Okay, C7. So that is totally spared. He cannot even keep his hand supinated. Suddenly goes into pronated. Did you see that? Suddenly goes into so much of a weakness of both the supinates. Isophysical supinatum muscle. So that is against the C6 radical. Okay, let us see upper and middle trunk. As Umar was telling, one point is deltoid. Other thing is that same 2 points by same point, the pronated teres and persecutor radialis, they're also separated by the C6, C7. And we cannot go with a middle trunk involvement or upper trunk involvement. So these are again. So what remains is what?
High radial nerve palsy, sir. High
radial nerve palsy plus muscular weakness. So this is to show the pathway. This is the diagram. It's the C5 root, how these fibers are supplying rhomboids, spinate, pectoralis, contribution to biceps brachialis, and through the posterior cord, deltoid and brachioradialis. This is C6 motor pathway. C6 root joins the upper trunk, contributes to spinate, pectoralis, biceps brachialis, deltoid, brachioradialis, rises 50%, extensor carpi radialis, and pronated. For C7, pectoralis, forget about the, not pectoralis, through the lateral cord to the upper trunk, it supplies pronated teres plus carpi radialis. So that is here in this patient, pronated teres side. And through the middle trunk, through the posterior cord, supplies the triceps, essentially digital, machines, the pollicis. They're all weak in this patient. So that can be explained. But what we can't explain is the pronated teres. So the diagnosis is right radial and muscular diagnosis. So what investigation would like to do? Now context study, no? Right, context. Right median is 4.8, left median is 13. So that means what? Some amount of affection of the right median is also there. PNR muscle is also affected. So then probably C8 root is also affected to a little extent. Not the root, that nerve may be affected to a little extent. But you must understand he has got multiple injuries on the upper limb. Some of them may be partially due to the compression itself. He has put on a plaster. He can very well have a compression of the ulnar is normal. Then that showing that the lower trunk is spared. Then the right radial is absent. The musculocutaneous right is very low amplitude, left is 9.4. So that is affected. Axillary is also less compared to that of it's elicited, but less compared to the opposite side. The axillary is also affected. That means some amount of compression is occurring in the plexus also. Maybe rotator axillary may not be only confined to that particular, but the front of involvement is in the radial and axillary. So radial and musculocutaneous. This is right radial sensory. See the medial lateral antebrachial cutaneous is affected as musculocutaneous nerve. But medial longitudinal is not septic. That should not occur. That will be lost only in the case of a medial cord or a lower trunk involvement. Probably again that may be due to some injury sustained under the, you've got multiple scars on the upper limb. So his injuries, right radial muscle cutaneous partial right axle. So what advice will you give to the surgeon now? He has referred to you for opinion. So what will you do?
We can do an EMG to look for recovery.
Yeah, this is already that's a good thing to do that. But even after this many months, he has not improved any weakness of the. See the look at the supinator power 0. So he has undergo surgery. Already past 3 months, he had to undergo surgery. So he had undergone surgery. Wound radial nerve repair was there. Any questions in that case? This case is not only for to localize. Why it is not CC7? Why is not primary involvement?
Sir, what is the result of the nerve repair? Does it work well?
No, if you ask me, I don't have much experience in that. I have seen people improving remarkably with after nerve repair that I have seen, but what percentage I don't know. What is not I don't know. They do improve remarkably, some of them at least. Yeah.
So what is the cause of the weakness? Is it the edema or some fibrous bands?
It's a cut injury. Cut injury. Shall we stop or go for one more case?
Yes, sir.
More, sir. One more, sir.
One more case. It's a little long case, still I can give no problem.
Suggest one doubt, sir.
Yeah, please.
Sir, what is advice you sir?
Surgery.
What is advice you should give to the surgeon? Sir?
You have to say, you have to do repairs, nerve repair.
Oh, sir. The maximum disability is the supination.
We have to see the only way to for him to recover is nerve repair. Okay. Someday neuroma may find the terminal end which is blocking the regeneration. So you have to re-explore and find out the nerve status and then cut the end and then re-switch.
Okay, seriously.
Sir, for that we need a MR or ultrasound, sir, because the nerve may be cut at the different levels. So we'll adjust them.
This requires re-exploration, direct observation.
Okay, sir. So the high radial nerve pulse may be in the axilla. We have to start from the axilla.
Yeah. They already know the site of injury. We know it's high.
Okay.
This is a story of a 63-year-old female. Is difficulty in walking and climbing stairs for the last 6 years. No history of weakness of upper limbs. This only combined difficulty in walking and climbing stairs 6 years. But examination, there are many more findings. Examination, you find ocular muscles were normal. Bilateral facial muscle weakness. Orbicular is more weak than the lower face. Lower face also affected, more on the left side. It's also weak. Parrot normal, tongue normal.
ഒന്നൂടെ നാക്ക് നീട്ടിക്ക്, നാക്ക് നീട്ട്. ആ ആ ആ മതി. നാക്ക് അങ്ങോട്ടും ഇങ്ങോട്ടും തള്ളിക്കമ്മ. മതി. തള്ളി കടിക്ക്. ഇനി വാ തുറന്നേ, ബലത്തിൽ തുറക്ക്. മതി.
It is normal.
ബലം കൊടുക്കല്ലേ അമ്മ?
The upper lip tone normal.
ബലം കൊടുക്കല്ലേ? എല്ലാം പറയും കേട്ടോ അമ്മ. ചുമ്മാ ഇട്. ഇനി ഇങ്ങനെ മാക്സിമം
Deltoid is mildly weak, not overcome.
പിടിച്ചോ.
But mild weakness is better.
പിടിയമ്മ, ഇതും പിടി. ശരി, ഇനി കൈ അകത്തോട്ട് പിടിച്ചേ, അകത്തോട്ട് മടക്കി പിടി, അകത്തോട്ട് പിടിയമ്മ.
Deltoid is normal.
ഇതും പിടിച്ചോ.
Sorry, biceps is normal.
മതി, വിട്ടേ. ഇത് നോക്കി
Biceps normal.
പോലെ പിടിക്കാൻ, സ്ട്രെയിറ്റ് ആയിട്ട് പിടിക്കണം, മടക്കാൻ സമയക്കില്ല. മതി, ഇതും പിടിച്ചോ. ഇത് പിടിച്ചോ. ഇങ്ങനെ പിടിക്കുന്ന പോലെ പിടിക്കണം. പിടിച്ചോ.
Wrist extension normal. Finger extension normal.
പിടിയമ്മ ഒന്ന് നല്ല ബലത്തിൽ പിടി. ഇത് പിടിച്ചോ മുകളിലോട്ട്. ഇത് പിടിച്ചേ. വേറെ അകത്തി പിടിച്ചേ.
Small muscles are also normal.
അകത്തി പിടിച്ചേ. ശരി, എൻ്റെ കൈ മുറുക്കും.
Hand grip is also normal.
അകത്ത് തന്നെ വിട്. മതി. മറ്റേ കൈ ചെയ്തേ.
No finger nose important.
എഴുന്നേക്കമ്മ. തല
There's no beware sign.
താത്തെ
You cannot lift up the neck from the bed.
തല മടക്കാൻ നോക്ക്.
Only because the neck flexes. Lower lip
ബലം കൊടുക്കുക.
is keeping its degrees assess the tone. But I don't think it is working. It's not there.
മാക്സിമം പിടിച്ചോ.
Flexion was weak.
മാക്സിമം പിടിക്കും. ഇത് പൊക്കി പിടിയമ്മ. വിടല്ലേ.
It is weak.
പിടിച്ചോ. വിടല്ലേ. മാറ്റണം.
Knee extension was weak.
തള്ളിക്കോ. ഇത് തള്ളിക്കോ. എന്നെ തള്ളു. സമ്മതിക്കല്ലേ.
Dorsal was weak bilaterally.
ഇത് പൊക്കി പിടിച്ചമ്മ. ചവിട്ടിക്ക് എന്നെ.
Flexion was weak.
ചവിട്ട്.
This was so weak.
മതി, വിട്ടോ.
EDM has the difficulties because the edema there.
അതിനെ പിടിച്ചോ.
Inversion was also
ഇങ്ങനെ
weak.
പിടിച്ച് നിർത്തിക്ക. നിർത്ത്. ഇനി വെളിയിലോട്ട് ഇങ്ങനെ എടുത്തേ. ഇങ്ങനെ ഇരിക്കണം. അങ്ങോട്ടാക്കാൻ സമ്മതിക്കല്ലേ. കീഴോട്ട് തള്ളിപ്പിടി.
Infections also
തള്ളിപ്പിടിച്ചോണ്ടേ
weak.
ഇരിക്കണം. വിടല്ലേ. അമ്മ കീഴോട്ട് ഇരിക്കണം. പൊക്കാൻ സമ്മതിക്കരുത്.
It is weak.
പൊക്കാൻ സമ്മതിക്കരുത്. തള്ളിപ്പിടി.
It's also weak.
ചേർത്ത്
Adduction was normal.
സമ്മതിക്കല്ലേ. അതേമാതിരി
Adduction was mildly weak on one side.
അടുപ്പിക്കാൻ
And also the tendon bed is later on. Upper lip fronts were normal. Ajax were almost is absent. Ajax were also absent.
കൈ മുറുക്കി പിടിച്ചേ. അതേപോലെ ഇത് മടക്കി അങ്ങനെ ലൂസാക്കിയിടേ. ശരി, മതി.
Plantar downgoing. Sensation is all low.
ഇല്ല, ഇതൊക്കെ അറിയുന്നുണ്ടോ? കുറന്ന് അറിയാമല്ലോ അമ്മ. ഇതറിയാം, ഇതും അറിയാമല്ലോ. ശരി, അമ്മ എഴുന്നേറ്റ്.
She could not get up from squatting position. Sitting position. The stool could not get up. Look at her gait. She's got a unilateral waddling. This side is not waddling. I will show the layer. It goes up on the other side. There's no waddling on that side. It is very weak. Neck extensions are normal. It's normal. And she's got trapezius. Arm abduction. Opposite extension. The so-called tongue extension sign is positive. This also will make her therapist because she's not able to elevate the arm above that thing. Open 90 degrees. She's a little more on the right side.
ശരി തിരിഞ്ഞ അമ്മ തിരിഞ്ഞ് പൊക്കി പിടിച്ചേ.
Could drop bilaterally. Look at the tunnel bug. See, you're standing on the right side, it's sagging, but on the left side, there is no sagging on the hip on the right side. See, there is no sagging, it elevates. They got a normal hip abduction on the left side, so they are on the left side. She cannot stand on heel or toes. This is another sign. What asks him to elevate the arm, the trunk goes into extension. That shows the weakness of bilateral. The trunk goes into extension. It goes backward. For examination, bilateral facial weakness, both upper and both upper and lower part or in the upper part. Other muscles affected by the rest failures are normal. Neck axis are weak, extensions are normal. Because both deltoid and elbow plexus has mild weakness in control. Weakness of both plexus, rest of the upper limb. Abdominal muscles weak, fever is negative. Lower limb, weakness of both hip axis and knee extensions, weakness of hip extensions. Hip abductors are weak on the right side because of the dental nerve, but normal on the left. Hip abductors are dorsally normal. Weakness of both dorsiflexus 8-4. Both abductors inverters are weak. Anterplexus also not normal, sorry, it's weak because she cannot stand on toes. Weak are normal, lower limb knee and ankle jacks are absent. Sensation is normal, weak bilateral foot drop. So, what is your diagnosis?
FSHD.
Yeah. So, first, do you think it's a myopathy or a radical neuropathy? What?
But the facial muscles are out of proportion. It seems asymmetrical. I think there is a palatal weakness also, sir.
The palatal weakness is doubt. I have suspicion, but it is not there.
Otherwise, the facioscapular humeral high on the list, but I would consider mononeuritis multiplex also, sir. Considering the
but absolutely no sensory finding. And you see, you've got a selective involvement. See, the facial part affected, then other muscles affected, trapezius is affected bilaterally. Neck flexors affected, extensions are normal.
Middle fibers are affected.
Yeah. So the lower limb also, the only we can't say selectivity and not because almost all muscles are affected. But asymmetry is there.
This small likely is myopathy only, but the facial weakness needs to be slightly asymmetrical. So
no, that can occur in facioscapular muscular dystrophy is one, where you can have a gross asymmetry.
But the reflexes are reduced in lower limbs.
Reflexes are reduced in the lower limb.
Reflexes, knee and ankle are absent. Reflexes.
Yeah, but those muscles are also weak. I won't agree with you. We don't expect that degree of reflex loss, but agree with that. And that's slightly odd point, but otherwise, the distribution of muscle weakness fits in with the myopathy because selective involvement of certain groups of muscles in absence of sensory.
And the patients have symptoms also mild only.
Yeah.
But the symptoms are there for quite long time. The disease is there for quite long time.
So in fact, I thought facioscapular muscular dystrophy that is my first diagnosis. So let us see the investigation. CPK was 282. Serum test 9.10. Then what test will you do? EMG, find out myopathy versus neuropathy. You do the EMG can differentiate. The neurogenic potential you can think of a narrow or anticonvulsant or not. That's EMG. EMG was such a myopathic disease.
Okay. ഒന്നും ചെയ്യണ്ട ചുമ്മാ ഇരുന്നാ മതി ഒന്നും ചെയ്യണ്ട
Very small amplitude, even mild, but it goes into complicated beds. But this is there's not much of a myopathic potentials, not spontaneous activity. And the thigh, typical myopathy. Deep my mild effort goes into completion. It's myopathic potentials. So what will you like to do?
Genetic test.
Right. So I need a genetic test. There is no genetic abnormality detected. Pathogenic, likely pathogenic means
FSSD genetic test is difficult, sir. FSSD will not be picked up in genetic test.
I had said previously picked up 2-3 cases genetic test FSHD. H1 paper also.
So muscle biopsy, sir, would that be any muscle biopsy?
But it's not, it will not be proving, it will be in the morning. It only is for teachers muscular dystrophy. For some of the inflammatory myopathy, you can find out different results can be seen in the FSHD. And many other diseases also can produce inflammatory changes. So what I did.
Was there any myotonia in this case, or myotonia?
No myotonia. Myotonia is a possibility you have to strongly consider. No myotonia at all.
So nerve conduction, sir.
Nerve conduction I did not do because the EMG showed myopathy. Otherwise, I would have got myopathy. But you have got a good point. We should do conduction as well. Because there is a suspicion of a neuropathy initially because of the absent annual check and knee check. That has to be done. But only point is that we did once you click EMG, EMG was normal. I would have definitely gone further. It showed myopathy potential. Then I thought we will not go for a test. So after genetic test,
What genetic test was done, sir? What genetic testing was done? Was it a clinical exam or something?
Clinical exam is done. This is written here, no? Clinical exam as well as mitochondrial genome sequencing.
Clinical exam may not pick up or something.
അങ്ങനെ ഒരു thought ഉണ്ട്.
Repeated DNA element or something is there which will not be picked up by a clinical exam.
That's a good point. I ought to look into that. So seeing this thing, what I did was send for a myositis panel because we have to always think in terms of treatable disease. If genetically, of course, seen, then I wouldn't have gone for that. The myositis panel, you find that Tiffy gamma is positive. MDA is mildly positive. Mainly positive is the Tiffy gamma. Whether it is significant.
Gamma presentation is not like this, sir. Patient will be very sick and all, no? Tiffy gamma.
Actually, it presents like inflammatory myopathy.
Yeah, it presents like inflammatory. This patient has no symptoms at all. She is having some difficulty in walking only, no? We only picked up the wheels.
He has complaints of difficulty in walking for 6 years. He has been gradually progressing. That is which he came. Whether there's a possible treatable disease you have to consider when this is came as positive. So then I checked up the Tiffy gamma. I was not knowing much about this Tiffy gamma. So there are just few words about the myositic autoantibodies also myositis. There are two groups, myositis specific antibodies and myositic associated antibodies. Antibodies found in patients with PMDM have been classified in others will skip. This also will skip. There are several classical MSA mean myositis specific. They are the classical one is ARS and only classical one is anti-Jo one. that are grouped as anti-synthetase antibodies. And as anti-MI2, that is in dermatomyositis, and signal recognition particle, that is in decimite. So then there are new other autoantibodies, which among them should be classified as myositis specific is not well established. Among the new antibodies, perhaps anti-TF1 gamma and MDA5 are the two that have been best evidenced to be considered as MSC. It's from literature. Also, both are associated with distinct clinical subtypes of dermatomyositis. And if gamma is linked to cancer-associated dermatomyositis, MD linked to amyopathic dermatomyositis. And this I will skip. This anti-Jo1 other things associated with anti-synthetase syndrome, myositis, interstitial disease, arthritis, Raynaud phenomenon, others. Anti-MA2 is the treatable one, with eminently treatable dermatomyositis, with good response to steroid treatment. Anti-SRP is our hypertensive myopathy. So anything else, all these things. So did a seeing NDTF is also the next chance of malignancy, did a PET scan, which did not reveal any evidence of any active disease. So what will you do?
Steroids, trial of steroids.
Trial of steroids, sir.
Yeah, that's what I need. So in fact, I do not know the follow-up because I put the patient back to steroids and asked them to come for follow-up. If the patient is not responding, I will stop after 2 or 3 months. There's no point in continuing. So try this because that's the only treatment thing we have at my hand. The point which Feroz said I have to look into whether there's any other test to confirm that research needs. But that is the thing which is strongly considered clinically.
Yes, sir. Actually, genetic test for this, actually, I checked for another patient. And
Yeah.
then I was told like this clinical exome may not pick up that.
Yeah, maybe correct, maybe correct.
DNA repeat or something. So
Yeah.
they say actually another test, a kit is there, a different kit is there, which has to be used.
Because I was also having in my mind, back of the mind FSHD all the time. Because this presentation, facial presentation, trapezius weakness, so-called the classical, it's the abduction that polyhead like that. They're so typical of FSHD. They can have distal muscle weakness involvement. So but since came at when I had one patient who had diagnosed genetically FSHD by clinical X. That is why I thought this test may prove it that. So I told the patient that I'm not sure. This only treatable thing we have in mind. So we can give a trial. The other thing anyway you can't treat. So it may let's have it. That's not what is. They were not sure this informative material. And duration is also 6 years. Okay. Any questions? We'll stop. Okay. Any questions? Shall we stop?
Yes, sir. Thank you, sir.
Good night.
Good night, sir. Thank you, sir.
Good night.
Thank you, sir. Thank you very much.
Thank you. Thank you. Thank you. Thank you.